Good morning, everybody. Welcome to Georgia Heart Grand Rounds. Any financial relationships of the planners and speakers with commercial interest has been mitigated. The speakers will disclose their relationships in their presentations. If you have a question for the speakers, please wait until the Q&A segment. The evaluation will be shared at the end of the program. If you're watching online, you may submit your questions into the question feature and we'll read it aloud. Your evaluation will be in the chat. And now it is my pleasure to introduce our first speaker, Dr. Aryeh Shander. Dr. Shander is Emeritus Chair, Department of Anesthesiology and Critical Care Medicine at Englewood Health in Englewood, New Jersey. He is also an adjunct clinical professor, Department of Anesthesiology, Medicine, and Surgery at Icahn School of Medicine at Mount Sinai, as well as a clinical professor of anesthesiology at Rutgers, New Jersey Medical School in New Jersey, and an adjunct clinical professor of anesthesiology at the University of Florida. He served as the executive medical director of the Institute for Patient Blood Management and Bloodless Medicine and Surgery at Englewood Hospital and past president of the Society for the Advancement of Patient Blood Management. Dr. Shander lectures nationally and internationally on a variety of topics, and he is top 5% publisher of anemia-related manuscripts. He published more than 230 peer-reviewed publications that have appeared in several prestigious peer-reviewed medical journals and numerous chapters and books. Please join me in welcoming Dr. Shander.
Thank you, Sarah, for that very nice introduction. Good morning, everyone. I guess winter is here early, so we're all bundled up. Let me just thank you again for the opportunity to speak to you this morning. I'm going to talk about patient blood management, a strong contributor to improved clinical and financial outcomes. The idea here is to give you more of an overview of patient blood management, how we sort of evolved into this, and again, some of the challenges that we have, but mostly, I think, some of the positive things that we bring to the table in terms of how we practice medicine today. So I'll start, first of all, with a disclosure. This is my disclosure slide. Again, as mentioned before, it's all been addressed. So going back to the issue of patient blood management, as I mentioned, why patient blood management in cardiovascular surgery? So we're going to be using the cardiovascular surgery patients, I think, in my discussion, to give you an idea of the total picture or the overview of patient blood management. But keep in mind that patient blood management is from birth to death. All patients clearly can benefit from that, but as I mentioned, we're going to use the cardiovascular surgery patients as the example today. So why patient blood management? So the first thing is that we have to tackle this issue called transfusion practice. I will demonstrate to you that we have clearly an area where there's a lot of gray zones, there's a lot of unknown, if you will, but also there's enormous amount of behavior when it comes to transfusion rather than evidence-based or scientific-based approach to patient treatment with transfusion. Because again, keep in mind, transfusion is a therapy. And I could stand here with Dr. Tibby for a whole hour to talk about transfusion as a therapy, never mentioning to you what it is the disease that we are treating. I'll give you an example. If we were to do the same thing, talk about insulin without ever mentioning diabetes, it would sound a little lopsided. So then there are some of the issues associated with transfusion in terms of patients' outcome, including the clinical and financial consequences. And again, I think we need to understand the difference between patient blood management and something called OBU, or optimal blood use, which again is a driver to reduce the amount of transfusions or to make them as optimal as possible. But that's a very different task, and the two are not the same. And of course, the last is how do we adopt this new paradigm? So I'm going to step back and talk to you about the deadly triad. These have been published in the cardiovascular surgery. You could see as back as 2013 by Marco Ranucci from Italy. But he described the deadly triad as you could see on the left, blood loss, anemia, and transfusion. So all three interact in a way that actually puts the patients at risk, and he calls them the deadly triad. More importantly is that each one of these risks, as you see, is an independent risk factor to patients. So independently, they all represent a risk to the patient, but when you put them all together, they're synergistic in terms of added risk to the patient. So we want to modify each one when we can. So as you see on the right side of the slide, each one of these elements of the deadly triad is modifiable. But many people feel that blood loss may not be modifiable in cardiovascular surgery. We actually, in all surgery areas, accept bleeding almost as a business as usual. In fact, we need to take a step back because bleeding during surgery is modifiable, and we do know that for the same surgical procedures, some of our surgeons may be very good at reducing blood loss, and others may not. So we know that there is some modifiable effort that can be made actually to reduce that. But one of the other areas of blood loss, which we completely ignore, especially in hospitalized patients, is phlebotomy. Actually, most blood loss occurs with phlebotomy than actually with surgical patients. And that causes anemia in the hospital. And when these patients in the hospital are phlebotomized enough, reduce their hemoglobin to a certain number or threshold, they will get transfused. Again, that's another modifiable behavior because the data actually shows that repeated phlebotomies don't really add to, in a significant way, to the treatment of patients or management of the patient's disease, except in two situations where we need to repeat bloods. One of them, of course, is a diabetic patient who requires blood sugars, and another is a patient developing AKI. Potassium is going to need to be looked at. Now, the modifiable, I just want to show you this in terms of blood loss in cardiovascular surgery. This is cardiac surgical bleeding, transfusion equality metrics. This was a joint consensus statement by the Enhanced Recovery After Surgery. Some of you know Eris and Cardiac Society and the Society for the Advancement of Patient Blood Management. So here, the two, PBM and Eris, if you will, marry to, again, try to modify blood loss during cardiovascular surgery. And I'm not going to go into detail, but you could see that there are toolboxes here in terms of things that can actually improve in terms of reducing blood loss for the cardiovascular surgeon. And again, in turn, if you reduce the blood loss, the risk of being transfused, the second part of the deadly triad, may actually be, again, avoided. We asked this question at a similar time, just before Marco Ranucci published his deadly triad. And the question, as you could see, what is really more dangerous, anemia or transfusion? And the fact of the matter, when we published this, we tried to look at the two as independent risk factors, although we knew they're tied together. And as I mentioned to you before, when you add the two risks, of course, an increase is synergistic. This was published in 2021. This data actually is not from 2021, it's from before. And what these lines represent, if you see over here, is the bright blue is no transfusion and no anemia, then the red is anemia, and then green is transfusion, and then the deeper color here, the purple, is when you have anemia and transfusion. And listed over here, you could see all the different adverse events that are associated with each one of these modifiable risks. And as you could see, for each one of these, the highest risk is represented by the combination of anemia and transfusion. But in fact, you could see that in all of these, anemia is an independent risk factor, as is transfusion when you're looking at the different bars. Damien Lepara and his group looked at this. This is the Virginia Cardiac Service Quality Initiative. They looked over 33 cohorts, and what they tried to, again, look at is a transfusion issue, the anemia issue, and then, of course, some of the clinical outcomes in terms of adverse events. And at the end, what they were looking at is mortality. AKI was one of the things that they looked at in terms of adverse events, and stroke was another. And what they were able to demonstrate is that as your anemia became worse, meaning that your hemoglobin or hematocrit levels decrease severely, what happens is your risk of both morbidity and mortality increased. At the same time, what they were able to demonstrate is, again, as your anemia got worse, the risk of being transfused, and I say it's a risk, the risk of being transfused increases. And when you put the three together, or the two together, what you end up with is an increased risk of adverse events. This is AKI. This publication was followed by an editorial, and as the editorial concluded, they said that anemia is bad, transfusion is worse, and both together are worse than either one alone. So again, going back to the triad, we've eliminated in our discussion blood loss, and I think we addressed it, that there is a modifiable risk here, but again, we're concentrating now on the two, which is anemia and transfusion. Now, our colleagues in Brazil published this in 2021. This was a large retrospective one-year analysis of a large cohort in patients undergoing cardiovascular surgery. And what they looked at is blood transfusion during or within 6 hours post-operatively, and they defined anemia as a hematocrit cutoff, which resembles what the WHO says. And you could see that 30% of the patients in this cohort got transfused. And they had 4 groups, and they had no anemia, anemia, no transfusion, no anemia and transfusion, and anemia and transfusion. And keep in mind, you've seen that already before in the analysis that Peter Tigbe published before. Their conclusion, which is not different than the other, as you could see, the increase in risk as you go down the line here, combining anemia and transfusion, but each one of those is an independent risk factor. They concluded anemia in patients undergoing coronary artery bypass graft with coronary bypass is bad, but blood transfusion can be worse, increasing at least 50% of the risk for mortality and morbidity or morbidity. So I'm only showing you again the tip of the iceberg on different publications surveying these two risks, and the answer from all of them is the same, that transfusion is a risk as well as anemia. But the number one risk for transfusion in all surgical patients, which includes CV patients, is the presence of anemia. If you enter into surgery anemic, your risk, again, starts off by increasing your risk of being transfused. The other thing is that it doesn't mean that if you get transfused that your risk actually starts at first unit and remains the same. In fact, Michael Mazefian and his group showed again with Larry Glantz a few years ago, and they looked at predicted risk of morbidity and mortality, the PROM assessment, and what they were able to show actually in their analysis is that each unit actually is additive. So you start off with a single unit of blood, and already your risk is higher. And there have been many publications over the last 3 years showing the high risk of a single unit transfused. But as you add more units, your risk actually increases in terms of outcome. This was another publication looking at ERIS. This is Perioperative Quality Initiative and Enhanced Recovery After Surgery. Again, ERIS from the ERIS Cardiac Society. And they also brought in, if you will, some of the elements of patient blood management. This came out of Duke, and I guess the Duke data shows that about 24% of patients going for cardiac surgery have a level of anemia. The literature actually states that as high as 40 to 45% of patients going for CV surgery are preoperatively have some level of anemia. The anemia itself needs to be diagnosed to see what the etiology is. Just because you have a low hemoglobin does not mean that we just have a single therapy. although for hospitalized patients, a low hemoglobin as a default treatment is always going to be transfusion. And that has to be changed because we need to look at the etiology of the disease we're treating and then treat it appropriately. And here again, what they were showing is that the risk of anemic patients is 4 times more to be transfused. And we could talk about the adverse events of transfusion, which we did before. So their conclusion again, that treating anemia before surgery reduces the risk of transfusion and hence also has the ability to reduce those adverse events. Now, I have to bring you back to the center of PBM and some of the, as I mentioned early on when I started, some of the challenges that we have with transfusion medicine, as we call it, as a therapy. This publication came from the International Society of Blood Transfusion. Clearly, these are the blood people, if you will, or the transfusion people. The title is Blood Transfusion, 1 unit too much or 1 unit too few, which strategy poses the smallest risk to the patient? I think, again, that everything we do in medicine is a balance between risk and benefit. And in this particular article, what you're seeing is they're only talking about the risk. They didn't have a single sentence addressing the benefit of transfusion, partly because, as you see from the text, the best transfusion strategy and the optimal dosing for packed red cells are still missing in most indications, and sufficiently powered prospective randomized controlled clinical transfusion trials for packed red cells in most clinical settings are urgently needed to reduce ill-founded clinical decisions and to base transfusion strategies on clinical evidence and scientific study results. Well, there are 2 messages over here. 1, we don't know what we're doing, and 2, I don't think there are going to be any randomized controlled clinical trials on transfusion because nobody wants to be in the control group. So I think that the message, again, is that we're dealing with a therapy that we really don't know much about, and we're using what they call ill-founded, but we're using basically culture. We know that transfusion differs from one clinician to the next and from one hospital to the next. So again, it's a major issue for us because A, there's adverse clinical events, which I mentioned already, but in addition to that, the cost of transfusing patients was not known until 2010, pretty amazing, but again, we published this in 2010, looking at the cost of transfusing patients in hospitals in the United States and Europe. And the yellow cylinders represent the procurement of blood, meaning what it costs to get the unit of blood into the door of the hospital. And the green cylinders represent the cost of transfusing that single unit into surgical patients. The red cylinders represent the cost of caring for transfused patients during the study. Essentially, what we're telling you is, in the United States, a unit of blood costs about $350. The data shows that the cost of transfusing that unit is anywhere between 3 to 4 times. You could do the calculation very quickly in your head that a unit of blood may actually reach above $1,000. Now, that $1,000 or $1,200 or whatever it is that you want to discount in terms of what it costs to transfuse the unit is not reimbursable. It's coming out of the DRG. So we have a lot of work to do in terms of cleaning this. So what's come up as a not necessary solution, but if you will, change in the status quo and raising the bar in terms of making sure that we actually give our patients the best, both in terms of clinical outcomes as well as reducing costs. And that's patient blood management. And we've known that there are many organizations throughout the globe that profess to be a patient blood management organization. Each one has a different definition of patient blood management, but there's an enormous amount of overlap. What we did is we got them all together and published a global definition of patient blood management, which is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. Not a single word about transfusion. Keep in mind, blood is an organ. It's a liquid organ. And again, it is probably the only organ that can reconstitute itself if we give it the right nutrients, but we don't. We actually replace patients with old blood from the blood bank that doesn't behave as well as their own blood produce. Some of the argument is that, well, your production of blood takes more time and we don't have the time. Well, I think that that is a myth which we need to examine for two reasons. Number one, the blood that comes to the blood bank is not as active as you think, and it takes quite a few hours for it to actually regain its posture, and some parts of that donated blood actually do not come back in terms of both the biology and physiology as well as the anatomy of the red cells. The other is that when we start treating patients for anemia, if we know the etiology and we direct our therapy to the etiology, they're going to start to produce red cells within hours. And those red cells, by the way, are young, active, and eager to supply the patient with what they need, which is oxygen and again, nutrients. The corners of patient blood management, again, published by the Society for the Advancement of Patient Blood Management, looking at those elements that I've described to you before. And it starts off with the big one, which is the management of anemia for all patients, as I mentioned, optimizing coagulation, which again, could mean anything from bleeding to clotting, and here interdisciplinary blood conservation modality, not just during surgery, but as I already mentioned, excuse me, for all hospital patients. And getting the patients in the center is making sure that we as the clinicians understand the patient's goal for their health, and again, work together to synergize the two with our goal and their goal together. None of that works unless we can demonstrate improved patient outcome. So just to, again, reiterate, patient blood management is not about blood transfusion, it's about patient outcome. And again, we publish this multiple times in different editorials and different journals. Again, trying to center the clinician, the fact that treating the underlying modifiable risks is our intent. As a result, we can reduce transfusion or the risk of being transfused by, again, managing the anemia and reducing blood loss. The two, again, will reduce exposure to allogeneic transfusion. This slide just demonstrates the difference between patient blood management on top and optimal blood use. Again, patient blood management focuses on person-centered decision-making and blood health. So again, the person gets to understand that this is an organ that actually can reconstitute itself. It also promotes therapies for anemia, bleeding, and coagulation. Again, we're now breaking down the cause of these conditions and trying to address that in a rational way, or evidence-based, as we call it. Employs informed choice, seeks to protect and build person's own blood. Again, we said that, again, this is an organ that can regenerate itself. The ultimate goal of patient blood management is improving the patient's blood health. As opposed to optimal blood use, you can see focuses on transfusion-related decision-making. And those you already saw that these are mostly cultural. This promotes evidence-based transfusion practice. Already I showed you from ISBT that that's not a very strong one, and employs informed consent versus informed choice. And here again, it seeks to improve better blood component utilization. Again, mostly it's product-centered, this is patient-centered, and the goal over here is to minimize the effective, or to maximize the effective dose of blood components, or to reduce the patient's exposure to blood components. As I'm moving quickly because my time is running out, this is just one of many publications looking at outcome of patient blood management. This is in multiple hospitals in Ontario, Canada, that employed patient blood management, the on-track group, 20 years. They're showing a reduction in allogeneic exposure of patients in cardiac and orthopedic surgery, which is sustainable. They also showed reduction of length of stay, sustainable. And you know that length of stay is linked to patient outcomes. What they also showed, a reduction in infection, again sustainable. And lastly, a significant reduction in resource utilization, reduction in cost. Now, I mentioned before that a lot of people are afraid to wait. In fact, when we look at our neighbors up north and in UK, we know that for cardiovascular surgery, and we know also for cancer surgery, that the waiting period allows us to actually identify the anemia and treat it appropriately, again, reducing the patient's anemia, as caring for the anemia, and reducing the patient's risk of being transfused. And we know that the outcome of patients, unless they're actually acutely requiring surgery, is not affected by those few days or weeks that we're going to manage the anemia and get them to the operating room with a, again, modifiable risk that's taken care of. So in conclusion, patient blood management in cardiovascular surgery is no longer an option in our point because, again, we could see both on all three levels, clinical levels, resource utilization, and, of course, outcomes, reduction of adverse events. This is no longer an option. This is something which we must do. Again, transfusion do not lead to blood health, but patient blood management does. The associated clinical and financial consequences clearly improve with patient blood management and are sustainable. And then patient blood management and optimal blood use can coexist, but I think that the message here is that they're not the same. And again, we know that in one hospital, Jefferson has adopted the new paradigm and is actually now showing US data also similar to the data that we've seen from our colleagues in Ontario, Canada. And with that, again, I thank you for the privilege of your time this morning.
Thank you so much, Dr. Shander. Does anybody have a question for Dr. Shander? Just raise your hand and I'll bring the microphone. Hey, Dr. Guy.
Why has there not been this is a great talk, by the way, phenomenal. Why has there not been a randomized controlled trial in cardiac surgery, at least in some subset of patients? Because most of what is shown is retrospective or registry data, which is inherently going to have a bias, right? If a patient's sicker, they're going to be more likely to get a unit of blood if they're not, and therefore their outcomes will be worse. Why don't we just do a randomized control trial?
So first of all, how are you going to structure that randomized control trial is going to be extremely difficult. But before I even get to that, let me just state that there is a notion in medicine that sicker patients get transfused because of their underlying comorbidities. And all the data to date does not show that. The first major survey done in orthopedic surgery and other surgery specialties was 1990, where actually it was shown that it had nothing to do with the comorbidity, it had to do with the culture of the surgeon and the institution. That was followed with another prospective study done on 18 hospitals, and this was in coronary artery bypass graft, where the patients were matched, including their blood loss. And again, if you went to hospital number 1, transfusion rate was around 20%. If you went to hospital number 18, you got blood coming in the door. Same surgery, same comorbidity, and same amount of blood loss. So we know it's a cultural issue. So that bias may actually not be a major one in the retrospective studies that have been done. The big issue, of course, is how are you going to get people or subjects to agree to be in the control group, because there is a very strong conviction that, again, blood is necessary. Now, we could do a third arm. And when you look at these trials that are using enormous amount of taxpayer money and coming up with no good results for us, but get repeated, which is the liberal versus restrictive transfusion trials, those are prospective randomized controlled trials, which have enormous amount of pitfalls in them, which we can address later on. But one of them is that they include patients who get pre-randomization transfusion. We never do that in other areas of medicine. We don't study antibiotics with patients who received antibiotics before randomization. We actually exclude them, but these trials don't. So that's a major confounder. But regardless, There should be a third arm to your suggestion, and that third arm is the treatment of anemia. No transfusion, treatment of anemia. To again demonstrate whether it's the hemoglobin level of transfusion or whether it's the anemia management that gives you the best outcome. But again, I don't see much that can be done unless you have a thought on how we could put together a prospective randomized controlled trial, transfused versus non-transfused in CV surgery. I know it's a long answer, but I can go on and on. Thank you for that. Good question.
Hey, thank you for this presentation. I'm one of the trauma surgeons here. I love your analogy between the treatment of diabetes without a diagnosis or treatment of insulin with insulin and blood use. The gray scale of anemia, when the hematocrit of 37.5 is the definition of anemia, obviously hemoglobin of 7, hemoglobin of 11.5 are very different in terms of how they would be responded to in a hospital setting and also in the operating room. So is there an inflection point that has moved? I know cardiac surgery has typically been different than the rest of hospitalized patients in terms of their transfusion goals, but is there an inflection point on that gray scale that a transfusion is more likely to be beneficial to the patient?
There is only one large publication looking at red cell transfusion outcome. And again, this was looking at 450 clinical scenarios, as you described, with different levels of hemoglobin. Now, your question is very good, but I think it's got multiple levels in it. The first one is if we separate just anemia from transfusion, there is no significant inflection point until you come to what's considered to be the reduction where DO2 affects VO2, meaning when oxygen delivery affects oxygen utilization. And there's only one publication showing that in humans, and that occurs around a hemoglobin of 5 grams per deciliter. But that could be individual because we've seen patients for whom blood is not an option, who have a hemoglobin less than 2 grams per deciliter, who end up with treatment going home, aggressive treatment going home. So going back to this, the 450 clinical scenarios in this publication where patients were transfused with anemia, it's interesting. They looked at appropriate as being improving health, inappropriate as reducing health, and again, the gray zone was neither, which meant that there was no benefit, only potential for risk. And what they found was that 12% of transfusion in 450 clinical scenarios had improved health of the patient. Very small numbers compared to 88, which actually harmed patients or actually had no benefit, only risk to the patient from the transfusion. So on whole, to address your question, I don't think a number is going to help us. We can actually discuss the whole fallacy of using hemoglobin as a threshold for transfusion. Notice I don't say trigger. The reason is that hemoglobin is a concentration. It's grams per deciliter. And your hemoglobin may be 8 in the morning and it could be 10 in the afternoon because your plasma volume may change. Your red cell mass doesn't change necessarily. So your red cell mass is absolute, hemoglobin is a relative number. And to use hemoglobin as a threshold for transfusion, especially in these big randomized controlled trials of liberal versus restrictive, those individuals don't understand the physiology of hemoglobin. And the 2 gram difference that I just mentioned, 8 and 10, ask anyone in the laboratory, that's within your standard deviation, so it's pretty wide. Again, we don't have a non-invasive way of looking at red cell mass, but you can sort of think about it clinically. If the patient has a hemoglobin of 8, and I mentioned before it goes down to 6, they're still reading the newspaper and they can give you, they can recite the paragraph back to you, they can get out of bed, they can do whatever they need to do with that hemoglobin of 6, you know their red cell mass probably hasn't changed. and that may be dilution. And we see that a lot in surgical patients because they resorb a lot of the fluids we give them. Day 2 and day 3 post-op, the hemoglobin goes down, but the red cell mass doesn't. So it's a great question, very complicated, probably needs about 2 hours to fully answer it. But the inflection point is now being studied, I can tell you, by our colleagues in Denmark, trying to look at what your question was, again, very thoughtful. And they're not, again, the data is not out yet, so I can't tell you if there is an inflection point or not. But most of the time, whatever the inflection point, if it exists, it has to be individualized. I could tell you that you could have 2 patients with a hemoglobin of 7, one cannot get out of bed, the other one can play soccer. So again, it's so individual that we can't really look for a single number to address anemia, unfortunately. It really has to be individualized. I hope it just gives you some inkling in terms of an answer.